I think there's a lot of confusion out there. I have a consulting side of my practice in which I do medical spa consulting, aesthetic consulting, all over the country, actually. And a lot of people don't understand when they see this term cosmetic doctor, and they see plastic surgeon, cosmetic doctor. There is a distinction because obviously cosmetic doctor, from a formative perspective, their under years could have been in different disciplines before they became a cosmetic doctor. And there are specific boards that are recognized, right? So can you go over that a little bit for our listeners and our viewers as to the distinction and the training that is distinctive between a plastic surgeon and a cosmetic doctor?
Absolutely. So for a cosmetic surgeon, and the word cosmetic is used all over the place.
It's ubiquitous. It's really, yeah.
Yeah. So it's basically, you can have an endocrinologist calling themselves a cosmetic physician. You can have an internal medicine doctor calling themselves a cosmetic physician. You can have, OBGYN. It doesn't matter. They just call themselves cosmetic, whatever. Now, cosmetic surgeon is a specific term that the group of cosmetic surgeons are trying to create clout and legitimacy for. And for years, there were no prerequisites. So cosmetic surgeon, there's this thing called the American Board of Cosmetic Surgery, which truly is nothing more than an LLC. Like I could create American Board of Joe Brown Sandwiches and make an LLC for it. Boom, it's a legal entity, right? And I could say, I certify Keith, you're now board certified. By what? By the American Board of Joe's Sandwiches, right? But you just say board certified. That's it.
Sure.
Okay. Now, American Board of Cosmetic Surgery typically is a quote unquote 1-year fellowship, where really it's an observership. And there are not many places in the country that have it. It's not overseen by something called the RRC, which is the governing body that looks at all residencies in the program that are ACGME accredited. That's the American College of Graduate Medical Education. And that is what standardized essentially the beating heart of medicine in the United States. So the ACGME oversees the GME offices in every training hospital to say, okay, this hospital has an internal medicine residency, a plastic surgery residency, a general surgery residency. Each of those have program directors. Each of those have exams that they take, research requirements, case requirements, all that. The American Board of Cosmetic Surgery has nothing to do with the ACGME. It has nothing to do with the RRC. There is a governing board that's called the American Board of Medical Subspecialties. That is what determines the fact that there is, in fact, an American Board of Medicine, an American Board of Surgery, an American Board of Plastic Surgery. The American Board of Medical Subspecialties does not recognize the American Board of Cosmetic Surgery.
And that's where you get the board certification, where you have to take tests, you have to show work that you've done, and you have to meet certain criteria.
For me to become certified by the American Board of Plastic Surgeons, which I am, I had to complete a residency in plastic surgery that was accredited by the ACGME. Okay, that's the national board that oversees everything to make sure that these residencies are legitimate. In that residency, I had to complete a certain volume of cases. I graduated with like close to 3,000 surgeries when I graduated residency, and it has to be certain types of cases. So I had to have X amount of head and neck reconstruction, X amount of hand reconstruction, X amount of cosmetic surgery, and in the cosmetic surgery, they had to be X amount of face, breast, body, limbs, like you name it. And all of that is overseen by the RRC. The American Board of Cosmetic Surgery loves to say that they're the only board that specializes in cosmetic surgery and they need all these cases. We spend 6 years learning about all of this stuff. It's not a 1-year thing.
So that's the difference in part.
Oh, it's huge.
Yeah, but I mean, the distinction, obviously, they form this LLC, this business that they're going to basically self-regulate and self-promote, not from a recognized entity.
Correct.
Obviously, from what you're talking about with the plastics. So it's a 6 years of.
There are two ways to do it. It's 6 years of an integrated plastic surgery residency, or you can go a classic route, which means you've completed 5 years of a general surgery residency, typically urology, orthopedic, or neurosurgery, or ENT, otolaryngology. And then you would have to do a 3-year fellowship dedicated to plastic surgery in addition to those years. So if you didn't get a straight 6-year program out of medical school, which is very competitive and hard to get, then you would do this longer road of about 8 years of training, plus or minus a year or two of research. Once you completed that training, now you're out in practice. You are what's called board eligible. Correct. So that first year of your practice, you are in what's called your case collection period. Okay. You're also studying for your written board exam. Your written board exam typically is taken in, I want to say October. If you pass that, then you potentially get to sit for the oral exam, which is the subsequent year. During your case collection period, which begins in July of your graduating year, and it closes March of the subsequent year. So you've got, what is that, about 8 months to collect a minimum amount of cases. And during that first year of practice, you need to collect a minimum amount of cases, but also a range of cases. You have to demonstrate that you have capabilities within the main scope of plastic surgery, okay? For all of your patients, for every patient you see, you have to go online, the American Board of Plastic Surgery, you have to register patient initials, their medical record number, their history and physical. You have to register the surgery that you did, the diagnosis that you did, the amount of time it took to do the surgery, whether or not that patient had any complications, and you have to register all of that. If you hit your numbers, then in March or April, then they will select from those cases just 5 random cases. Of those 5, and when I say random, they will look for cases that stand out. Like if it took you 4 hours to do a breast augmentation, they're going to pick that because they're going to want to know why it took you 4 hours to do something that should take 1, maybe 2 at most. They will look at complications. If you have a complication, they're going to pick it because they're going to want to know what happened, what you did to fix it.
When you say they, who is on this board that's going to be asking these questions? The
American Board of Plastic Surgeons.
So there'll be other surgeons, plastic surgeons?
Yeah. Exactly. Experienced plastic surgeons who have been, in good standing, that are part of the board of oversight that determine are these surgeons safe enough to be deemed plastic surgeons. But it's not just safety. They look at technical capabilities. They look at your judgment, big time focus on judgment. They look at your ethics. So of the 5 cases they select, you have to put everything in. You have to put in your initial consultation note, every consultation note of any other doctor that saw that patient, every progress note that you saw them make. If you saw them twice a day, that's 2 notes per day. All their labs, their imaging. You have to put in your HCFA form, which is the insurance billing form. You have to put in your before and after photos. You have to put in progression photos throughout. If it's a cosmetic surgery, you have to show them the quote that you gave to showcase that you're offering ethical and reasonable costs for your procedure.
So it is everything. It's a forensic analysis.
It is, I'm going to quote Jerry Seinfeld. It is the professional equivalent to a complete rectal exam.
Yeah, it sounds like it.
Yeah.
It sounds like it. And how many individuals are analyzing all this data?
So you send it to the board, and they will assign doctors to them. And then what happens is once they look at your books, they'll determine if you're okay to sit for the oral exam. If, for example, you have a patient, let's say you have a patient that there's no after photos, right? Because you could say, what if I had a crappy outcome? I don't want them to see it. I'll just say, oh, this patient was lost to follow-up. If you have a book that's incomplete, you can either you're done. You can either take it the following year, or you can submit 10 other books. So instead of doing 5, you'll have 14.
Wow.
10 other books. And these books, I'll show them to you one day. They're ridiculous. Like I had one patient who was an ankle reconstruction. He fell off a ladder from like 40 feet and his ankle blew out through his skin. And he had a rip-roaring, devastating infection. So we had to do some fancy work with an orthopedic surgeon that I work well with. And, he was in the hospital for about a month and a half. I rounded on him twice a day. His book was this thick. It was insane. And anyway, if you're allowed to sit for the exam, then what happens is it's a 3-day exam. So you show up in this hotel in Arizona, and most of us don't like going to this area in Arizona anymore because it's stressful, man. And
you'll probably have PTSD from it.
Oh my gosh. So my study buddies, we all crushed it. And so we felt very prepared for the exam. Ohio State trained us very, very well. And we all smoked the exam, but still it was daunting. You go there, you submit your books. There are 3 days of exams. There are 2 days of unknowns and 1 day of knowns. The unknowns are basically they give you a booklet of 10 different photos of patient images, and underneath is a little blurb, 42-year-old female, 6 weeks out from surgery, and it'll show a photo of a surgical outcome, and I have to be prepared to discuss that. The next one will be, I remember one was a pelvic defect after somebody had their anus and their genitalia removed for cancer. It was a big pelvic defect and it said, 50-year-old smoker, history of radiation therapy. And so you go in this courtyard where you're standing, the hotel has like external doors, and you see a sea of people in black suits and terrified expressions on their face, just sitting on these little steel chairs, waiting to go into their hotel room for the exam.
So they do it in masses.
Oh yeah. There's about 100 something of us. And you're just sitting there and you look around, you can just see everyone's just eyes forward. And they open the door, they say, here's your book. They close the door, you look through to prepare yourself. And then you get up and you go in and they say, okay, have a seat. I'm Dr. So-and-so, this is Dr. So-and-so. With which case would you like to begin? So I just opened it and you go, okay, here I see a 50-year-old female smoker whose status post-abdominal perineal resection and a history of a radiated wound and requiring reconstruction. How do you want to start? I want to make sure this patient has adequate nutrition labs that are CBCs. And once they see that you can work up the patient appropriately, they'll skip and they'll go, okay, you do all that is fine. What's your operative plan? I would do a rectus abdominis, myocutaneous flap with deepithelialization to obliterate dead space and to fill the void with healthy vascularized soft tissue. And they say, okay, well, you go and do your dissection, but that flap fails. What's next? I would do a bilateral gracilis muscle flap with split thickness skin graft. The gracilis flap doesn't work. Next. What do you do next? I would do a posterior thigh flap. How do you dissect that? I make an incision a pennant incisions, on the medial and lateral aspect of the thigh. I would dissect in the subfascial plane up to the point of the inferior gluteal muscle penetrating through the adductor long. And they're like, okay, next. So you have to demonstrate that you know what to do. And then they would always give you a complication. And so, for example, that day, those are your unknowns. On your knowns, you walk in and they've got your books. Okay, your books are sitting right there. There are leaflets all over it, highlighted. It's just they have just completely, they've gone through your books with the highest level of scrutiny. And then they just go through. They're like, tell me about this case. And you start telling them about it. What happened with this? Why'd you choose that? What would you do differently? Do you think this is a good outcome? How did you come up with your billing for this? How did you come up with the coding for this? And they will push you. Like I have a friend who failed his exam, despite the fact that he said the right thing. This patient had a melanoma on the face. He had a plan. He said it, and they said, "You sure you would do that?" And he said, "Yeah." And they said, "You're sure? That's how you want to do it? You wouldn't do this instead?" And he was like, "Well, I mean," they're like, because blah 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 blah. And he said, "Okay, well, no, I'll do that instead." Fail. So they test you to make sure that you will stick to your guns and do the right thing, regardless of outside influence. It is in my opinion, I don't see any other way to do a generalized certification to demonstrate capability and sound judgment.
I hate to be so blunt about it with all your medical terminology, but you're filtering out the weak.
Oh, totally.
You're filtering out people who shouldn't be in that particular role.
That's exactly right.
And in spite of their perceived arrogance or skill set. I mean, it's one of those things because it's a holistic approach, right? You're not just, you may be the most incredible tactician with your hands,
right,
but you have no way to analyze a problem.
That's exactly
so
right.
Guess what? You're not in that role. Maybe you're in a role of microbiology or something. You know what I mean?